Thank you. Before I begin, I want to compliment the minister. He has already transformed the South Africans' healthcare, and that's really illustrated already and acknowledged by the world, like the Lancet published your accomplishment, how you have improved the life expectancy and infant mortality of South Africa. My presentation is about the global lessons in planning, implementing national health insurance. And in the next 20 minutes, 25 minutes, I plan just to give you what I consider 4 major lessons. And I want to draw on the experience of many countries because the national health insurance's term, or social health insurance, or universal health coverage, that concept was really created more than 100 years ago. And many countries have adopted, and here I show that for advanced economies, it started in Germany, and I listed several countries. But then this idea of national health insurance has blossomed forth in the past decade or more, and I listed the more recent countries. And the best example usually that's considered as a success is Thailand. And the more newly industrialized nations that's considered is a success is Taiwan. These are the 2 countries that's trot out. Brazil is put forth as successful developing primary care, but they actually have not dealt with their hospital care sufficiently. And Colombia follow a different model. So without enumerating all of this, I just want to try to summarize 4 lessons that to stimulate and provoke this audience, as well as to introduce, to discuss and think about national health insurance, which is a vehicle, as I see it, that South Africa, and led by the minister and his team, trying to really transform the healthcare delivery, financing for all South Africans, and to produce equitable and equal access for everyone to high quality of healthcare, to improve their health as well as to reduce the health expense induced impoverishment. So let me just say, what are usually a country embark on a national health insurance journey? Because this is an instrument to trying to improve or to realize the vision that has been put forward for South Africa. The 3, I can list 3 just right off, usually is 1, how do you provide effective coverage? And I will expand on that in a minute. But second is, a country usually have limited resources. And that varies depending on your level of socioeconomic development. So the need usually is much greater than what you can afford. So there's a budget constraint. So the issue is what's affordable. Then often the political commitment could be very strong, and they decide to give a big push. But then we observe in other countries that a new government come in or a new minister come in, then the whole program actually just not petered out, but definitely just stagnant. I can give you cite 1 example. Philippines introduced a national health insurance. We thought it was a leader of the world in the early 1990s. today you don't even hear about the Philippines program. They made a political commitment, then 2-3 years later, actually, they have no money for it, they have no infrastructure for it, and then, so now that 20 years later, they are still really do not have what you and I would call universal coverage. So sustainability is another issue. So I want to then share some lessons. First is we learned insurance coverage is not equal to effective coverage. And I talked to the minister before when he was at Harvard. And I want to commend South Africa. You're already doing as much as you can to build up the primary care, prevention and primary care through your community health workers, and you're trying to contract private physicians to clinics. So you're trying to develop this effective coverage. But how is that going to be done? How much resources do you need? I just came from Ethiopia. They're moving to national health insurance. And they right away is committed to build 800 district hospitals, new district hospitals. That surprised me. Ethiopia would do that. But of course, they already have they already have the so-called extension health workers that create produce the results for the prevention and control of communicable diseases. So so the effective coverage, I know South Africa is already paying attention to, but I just want to highlight. In the world, we learned insurance coverage is actually easy to achieve. Particularly if you say, I pay part of your premium or I pay all of your premium. But insurance coverage does not mean people have access to adequate health care, reasonably good quality health care. Number 2 lesson, I'm not sure it's this germane because I don't know about what's in the new white paper that's going to be released soon. That's what I understand. But I just want to alert this audience. There are 2 kinds of social health insurance programs. One was developed by Bismarck in 1881. It's what we call the Bismarckian, and that's a 19th century social insurance program. You please note, what that does is first cover everyone who are civil servants, usually, plus employees in the formal sector. People who are in the informal sector, including farmers, are not covered. And the poor people really are not covered either because they cannot afford to pay the premium. So usually the country then develop public health services for the poor people, but those services usually have very low quality. And so it's not providing equal health care to everyone. And the 21st century social insurance model is very different. And I observe many countries in like Tanzania, Nigeria, Kenya, in Africa are already all making the same mistake. Namely, they follow the Bismarckian one. They cover the civil service and the formal sector employees first with very rich benefits. To try to then bring the poor people, the informal sector up there, it takes so much resource, they cannot make them converge. That's the experience of Thailand. The minister mentioned Mexico. Mexico followed the Bismarckian model. Civil service has a very rich benefit package and access to excellent health care. So does the formal sector workers, including their oil company, which is a state enterprise, employs tens of thousands of workers. But when Mexico trying to get everybody into an insurance plan, they could not bring them together because it costs too much money. Same thing with Thailand. So when you hear about these success stories, there's a downside. They are actually not providing equal access or equal quality of care. They have tiered. The 21st century model is you have to tax or get the revenue from the people who can pay. Usually they are the civil servants and formal sector workers. But then right away, at the same time, government use different revenue sources to bring in the poor people. So then you're like a dumbbell. You bring in the top people in the economic sense into an insurance system. You also bring in the poorest people in. Then you fill in the middle. And the filling in that middle, like Indonesia is trying to do, Indonesia has not been able to fill that middle even for a decade, although the president and his cabinet is making a serious commitment to it. Colombia also did this dumbbell approach. Colombia has not been able to fill that in for 20 years. So, but the countries then is embarked on a road to fill it in. What does that mean? Let me just then move to the lesson number 3. And this may not apply to South Africa. What we learned is do not start out by promising a comprehensive coverage, covering most of services or 95% services. Usually that kind of benefit package is not affordable or sustainable unless you become a high-income country. Then what's said in the benefit package is a rhetoric, are just words. Services not available because you cannot afford it, so what you do is you ration. There may be only one, let's say, dialysis center in a small country. So people have to wait for 5 years before they can get that dialysis. So on paper, we cover dialysis, but in reality, very few people have access to dialysis. So the question usually then, why do you promise that? What's the risk when you promise that? Is there any risk? The risk actually is people get disenchanted. They look at it as an empty dream promised to them. Over time, actually people become very cynical. Countries actually vote out governments on that basis. They say, you promised me this set of benefits, but actually after 5 years, you could not deliver. Colombia is an example I want to cite to you. So usually the lesson number 3 we learn is you have to prioritize. Then the question is, which population group do you want to give first consideration? Second is what services receive priority consideration. And here I think the minister, from what I learned and observed, he already prioritized prevention, which you are doing a wonderful job, as well as primary care. And then the question is related to lesson number 1. How do you develop the capacity to even deliver what you promise people, even if it's primary care? Do you have the human resources to do it? Do you have the facilities and equipment to deliver it? So then here, let me go to, I'm just portraying a simple in diagrammatic form here using WHO's framework, but we modified it, trying to be more useful. They developed a so-called cube. And this vertical line here is the depth. So-called depth means for the health services, how much is covered by a national health, by insurance. And then this is called breadth. That is the population. What proportion of people have the coverage. And then this is called the scope, what services are covered. I did not use South Africa's data to draw this diagram, but I used an African nation. One of your neighbors actually produced this diagram. I have slaves, otherwise known as graduate students. We don't pay them much, and they can do very good work. So, this is the current situation. In other words, you see, usually the higher income group, the top 20%, they already have some insurance, private insurance, or through their employment, or some other coverage. And you see the next level, 30% has much less. The bottom 50%, the poor people, actually, some of them have nothing, not even prevention in this country. And they are worse off than what South Africa is. So the question, if you want to prioritize for the low-income people, then what you want to do is this. You fill in the most cost-effective services for the poor people, for the people who have nothing. And then, next stage, when you have more resources, you can raise that. You don't do much for the rich group. But then, what we observe in Africa, I mentioned Tanzania, Nigeria, Kenya. This is what we observe. They actually, for political reasons as well as what effective services they can produce, what they are doing is, that's the resource allocation and coverage. So this is lesson number 3. And I just came from Ethiopia. I don't mind to tell you, I advised the cabinet and Minister of Health, say, you should take this lesson number 3 seriously, because they are going to do really is get the civil servants covered as well as the former sector employees covered. Then let me just go to lesson number 4. National health insurance is a long journey. Thailand, actually, which is considered a success story, or Mexico, which is considered also done quite well. Thailand began to build up a think tank in their country so they can collect the data, do the analysis, and produce the evidence what the country can do and should do. Then they build up they know they cannot get the physicians to the countryside. So they begin to build up schools for nurses. They require the physicians graduating to serve in the rural areas where there's a shortage of doctors. But more than half of them escaped. They could not really enforce it. Let me tell you, other than communist countries, we did not find any country can enforce that, to require medical school graduates who receive free medical education to go to the countryside to work. They use various devices, including migrate out of the country to escape. So usually this has to be a national health insurance to cover everyone, as well as to develop effective services. Usually requires at least a dozen years, maybe up to 20 years, even when a country is growing very rapidly. China introduced it in 2003. A decade later, China gave 125 billion US dollars to develop minimum benefit package for everyone. But even now, 97% of the Chinese are covered, but many of them do not have effective coverage. This is a decade later. So China is right now trying to develop this effective services down to every village. So it's a long journey, and I admire what the minister is doing. He's laying out a 15-year plan. So he's already, without being ever heard this kind of speech before, he already say, I'm going to do it over stage by stage. And I don't have, but then let me just end with my observation for South Africa. To me, South Africa has a unique challenge, which we don't observe that very much in any other nation, other than the United States. But the United States is using a different pathway to trying to achieve universal health insurance, and a very expensive one. Just for your information, United States today, the average health care cost per person in year 2012 was $8,700. US, $8,700 per person. That still leaves us with 50 million people uninsured. It's consuming close to 18% of our GDP. Here, the charge d'affaires, Virginia is right here. I was, as an American citizen and a proud American, but for health care, my advice to other countries, learn what not to do from the United States. So, your unique challenges, you have somewhat similar situations in the United States. You have really a dual system here, because that was developed under apartheid. And it's entrenched. That's you have a two-tiered healthcare, financing as well as service provision. And they are divided into public and private, usually. And there's a huge disparity in availability and quality of services between the two. And the costs of these services are also vastly different. In the private sector, the cost is much higher. And in your speech yesterday, which I read, you're commenting on what's going on in the private sector. And so, how could you bring something up here down? Or you can try to bring the bottom up. If you bring the bottom up, you need tremendous amount of resource to do that. If you're trying to bring the top down, you can imagine the political resistance. You can anticipate the people who are going to be affected, regardless they are the beneficiaries of the insurance plan, or they're the providers, or your medical aid schemes. At least we observe in other countries, these are powerful political forces. So to me, I want to say South Africa has a unique challenge, and I think the minister and your team has done a wonderful job. I know you have considered all of this, and I'm waiting for the white paper to see how you were trying to meet this challenge. Thank you.